He's edited Palliative Care-Based Case-Based Discussion by Oxford. He is also an editor of the South Asian edition of Clinical Anesthesia by Barash, as well as Dorsch and Dorsch, and has several publications to his credit, more than 200 in several indexed national and international journals. We welcome you, sir. The moderator for this session.
Thank you, Nitin. Before we start, I thank the organizers, especially Dr. Akhilesh and Dr. M.D. Kaur and the whole RML team for giving this opportunity. So renal transplant is an important case for anesthesiologist, and there are a lot of intricacies involved. As a student, you may not get a transplant case per se, but you will get a patient with CRF posted for surgery, which may not be related to the transplant itself, or you may get a patient who has a renal transplant and is posted for an incidental surgery. But yes, the concerns remain the same, and we'll try to focus this on renal transplant only for this presentation. So Dr. Priyanka will present the case first, and then we'll take it forward. Priyanka, please, over to you.
Good morning, sir. So I'm presenting the case of Mrs. Renu, 40 years old female. She is a Hindu by religion and a school teacher by occupation. She resides in Rohtak. She presented with the chief complaint of decreased urine output since the last 1 year and swelling in face and legs since the last 7 months. History of presenting illness. She has a complaint of decreased volume of urine since the last 1 year. Onset is insidious, gradually progressive. She has no difficulty in voiding. Initially, frequency was 6 to 7 times per day. Volume was 2 cups per urination. Current frequency is 2 to 3 times per day and volume is half a cup per urination. There is no history of pain in the flank region or any radiating pain to perineal region. No history of fever, pain or burning micturition. No history of foul-smelling urine, frothiness or blood in urine. No history of consumption of any Ayurvedic medications. She also has a complaint of swelling in the face and the legs since the last 7 months. Insidious in onset, progression is gradual. Face swelling is more prominent around eyes, noticeable more in the morning when she wakes up and gradually decreases as the day passes. Swelling is uniform around the eyes, not associated with redness, itching or pain. Leg swelling is limited to feet and it increased as the day progressed, aggravated by increased fluid intake and prolonged standing, relieved by decreased fluid intake and rest. There is no history of breathlessness, palpitation or abdominal distension, no history of chest pain, dyspnea or orthopnea. There is no history of excessive thirst, hunger or vision changes, no history of recurrent sore throat or skin infections, no history of skin rash or joint pain. Meths are more than 4, and patient had a history of fatigue and decreased appetite, which got relieved after starting dialysis. In past history, my patient is a known case of hypertension since the last 8 years, compliant to medication and controlled. Known case of hypothyroidism since the last 1.5 years, compliant to medication and controlled. There is no history of diabetes mellitus or any other comorbidities. No history of any drug allergy. No history of any surgery or anesthetic exposure. No history of blood transfusion. My patient is on the following treatment.
We'll come back to the first slide again before we go to treatment history.
Yes, sir.
So we have a patient who presents with decreased urine output and swelling in the face and legs. So what is the first thing that will come to your mind, and what are the possible systems that may be involved if such kind of presentation is there in the patient?
Sir, in such kind of a presentation, I will think about a cardiac issue, a kidney issue, or a liver disease.
Okay, so and what are the others? Come to the next slide.
Yes, sir.
Okay, so So you have specifically asked for this flank pain and fever. What does this mean, and why do we specifically ask for this such things in?
Sir, I want to elicit history of pain in the flank region to know about if there is any obstructive uropathy due to any stone. Pain, fever, burning micturition to know about history of urinary tract infections. Frothiness can be due to and smell foul smelling urine can be due to infection or proteinuria. Blood in urine is for hematuria, which is in case of glomerulonephritis, because these contain heavy metals. So I want to rule out heavy metal toxicity.
Hello,
Yes,
I'm audible?
sir.
Okay, so
Yes, sir.
come to the next slide. So how do we, by the history, can we kind of come to this thing that the swelling in the face and legs is due to primarily a renal cause or a cardiac cause? Because edema may still occur in both the cases.
Yes, sir. Sir, I can ask about history of dyspnea, orthopnea, any chest pain, to know about if there is any cardiac cause. Abdominal history of abdominal distension will tell me about a liver cause. So rest of the things would be like if after I examine the patient, I can be more sure about the cause of edema.
Okay, okay. Please go ahead.
My patient is on the following treatment. She's on tablet amlodipine 10 milligram BD and tablet telmisartan 40 milligram BD since the last 8 years. She was started on tablet torsemide 20 milligram OD since the last 7 months. My patient is on tablet levothyroxine 50 micrograms OD for thyroid disorder. Injection erythropoietin 4,000 units twice weekly since the last 7 months. She's taking tablet calcium 500 milligram BD and vitamin D3 sachet 60,000 units weekly. She's on hemodialysis since the last 7 months. Initially, it was done twice per week in the initial 5 months. Now, since the last 2 months, she's undergoing dialysis 3 times per week. Each dialysis session lasts for 4 hours. And last dialysis session was 2 days ago, which lasted for 4 hours and was uneventful. Initially, dialysis was done through catheter placed in the groin, followed by neck, and then AV fistula was created in the left forearm under local anesthesia. Personal history, she's married. She has a 10-year-old son. Her husband works in IT company. She's non-vegetarian, non-smoker, non-alcoholic. She has normal bowel habits, normal appetite, normal sleep-wake cycle, no known allergy to food. She lives in a nuclear family and there are no similar complaints in the family. She belongs to lower middle socioeconomic class. She attained Minaki at the age of 12 years. Menstrual cycle is regular with normal flow lasting for 3 to 4 days. Last menstrual period was on 22nd of November. She's para 1, live 1 with full term normal vaginal delivery at a hospital 10 years ago. For examination, informed consent was taken from the patient prior to proceeding for general.
Before we go to examination, so let us come to the history again. So what do you think is a possible diagnosis, differential diagnosis, likely one? What are the alternate diagnoses and what are the concerns in such a patient? Before you start.
Sir, my possible diagnosis based on history and treatment history, past history will be my patient is a known case of hypertension and hypothyroidism with the insult to kidney, chronic kidney disease on dialysis.
So it looks like patient had hypertension earlier and it has led to chronic renal disease, and presently the patient has chronic kidney disease on dialysis.
Yes, sir.
So what are the other possible comorbidities such a patient is likely to have?
Sir, if after starting of dialysis. And if the patient has CKD, patient is also prone to have hematological, cardiovascular, and neurological abnormalities. Sir, in the cardiovascular system, because of fluid overload, there will be systemic hypertension, which is already pre-existing in my patient. So because of hypertension, there is left ventricular hypertrophy, and after that, there can be congestive cardiac failure also. Sir, there is tachycardia to compensate for anemia in these patients. Sir, there is accelerated atherosclerosis, which can lead to coronary artery disease or ischemic heart disease, which can result in arrhythmias and conduction blocks. So because of uremia, there can be uremic cardiomyopathy, pericardial effusion, or pericarditis.
So it is important to know, because before we examine, we should know what kind of possible systemic involvements might be there in such a patient. And
Yes.
you can focus more on those specific areas when you are examining the patient. Okay, so we go to the examination part.
So I took informed consent from the patient prior to proceeding for general physical examination. Patient is conscious, cooperative, oriented to time, place, and person. She is sitting comfortably on the bed, moderately built and nourished. Weight is 60 kilograms, height is 160 centimeters. BMI calculated was 23.43 kilograms per meter square. Pallor was noted. There is no icterus, clubbing, cyanosis, or lymphadenopathy. Bilateral pitting pedal edema is present. Neck veins are not engorged. Pulse rate is 88 per minute, palpated on the right radial artery. It is regular, good in volume and character. Arterial wall non-palpable, no radio-radial or radiofemoral delay. All peripheral pulses are palpable. Blood pressure is 136 by 84 millimeter of mercury measured in the right upper arm in sitting position, and 130 by 80 millimeter of mercury in standing position using appropriate sized cuff. Respiratory rate is 15 per minute, regular, thoraco-abdominal. Room air saturation is 97%. She is afebrile to touch. AV fistula is seen in the left forearm, which is pulsatile, non-tender. There is no redness, and a thrill is present. Groin mark of past IV catheterization are present. Venous access seems to be difficult.
Okay, Priyanka, so what is an appropriate cuff to measure blood pressure? How do you decide that this is the appropriate size?
So the cuff circumference, the circumference of the bladder should cover 80% of the arm circumference, and the width should be 40% of the arm length.
Please go ahead.
Sir, in airway examination, she has good oral and dental hygiene. There is no loose, artificial, or buck teeth. Upper incisor length is 1 centimeter. Interincisor gap is 5 centimeter. Calder's test, which shows a normal functioning TM joint. She is able to bring her lower incisors in anterior to the upper incisor. Modified Mallampatti class is 2. There is no arching or narrowing of palate. Thyromental distance is 6.5 centimeter. Hyomental distance is more than 6 centimeters. Sternomental distance is 13 centimeter. Neck circumference is 33 centimeters. Range of neck movements is normal, as demonstrated by Deligan's test.
So essentially, it appears to be normal.
Yes.
Okay. Okay. So next, please.
So cardiovascular system examination. On inspection, chest wall is symmetrical in shape, precordium normal in shape, apical impulse not visible, no engorgement of jugular vein, carotid pulsations are not visible. On palpation, apex beat is present in the 5th intercostal space, 1 centimeter medial to left mid-clavicular line, no parasternal heave, no appreciable thrill or pulsation in any area. On auscultation, normal S1 and S2 is present. No murmur or added sounds heard.
So Priyanka, if the patient had some systemic involvement in the cardiac system, what findings we would expect?
Sir, tachycardia I'll expect because of anemia. I can have hypertension because of fluid overload. Sir, after that, there can be a pericardial rub because of uremic pericarditis, and if the patient has congestive cardiac failure, I can hear a S3 gallop sound. Sir, in case of again, in case of congestive cardiac failure and pulmonary artery hypertension, there can be a murmur of tricuspid regurgitation, which is a systolic murmur.
Okay, good. So, next.
Sir, in respiratory system, on inspection, respiratory rate is 15 per minute, thoraco-abdominal. Bilateral chest movements are equal. There is no audible wheeze or stridor, no usage of accessory muscles of respiration, no dilated veins, pulsation or scars over chest wall or back. On palpation, trachea is midline in position, bilateral equal movements of chest wall. Vocal fremitus normal and equal on both sides, no tenderness or bony deformity. On percussion, there is a resonant note in all areas in sitting position. On auscultation, bilateral vesicular breath sounds in all areas, no added sounds, vocal resonance is normal. In abdominal examination, on inspection, abdominal is normal in shape, umbilicus is central in position and normal in shape. Scar mark is present on bilateral groin region, no sinus or venous pulsation, no visible lump. On palpation, all 9 quadrants palpated, they are soft and non-tender, there is no fluid thrill, no organomegaly. On percussion, tympanic note was heard on percussion, no shifting dullness. Upper border of liver dullness is seen in the right fifth intercostal space at mid-clavicular line. On auscultation, normal bowel sounds heard. In central nervous system, higher mental function is normal, cranial nerves are intact. Motor function is normal in tone and power, no atrophy, no abnormal movements. All sensory function and reflexes are normal. Normal gait, cerebellum and autonomic function is normal. There is no history of sudden loss of consciousness or slurring of speech or altered sensorium.
So, in the neurological symptom, what are the changes we may expect? So, because of the CRF per se or because of dialysis?
Sir, because of uremia, first of all, there can be uremic and features of uremic encephalopathy, which will include, which can range from agitation, altered sensorium, irritability, changes in behavior to coma. Sir, after that, there is an autonomic neuropathy, and there is a peripheral neuropathy of a distal mixed sensory and motor type, which is distal in nature. And sir, because of dialysis, there are 2 syndromes, which is dialysis dementia and dialysis disequilibrium syndrome.
Okay. So, this patient has none. So, patient was well preserved with respect to uremic encephalopathy, and dialysis is because of dialysis, the toxicity is not occurring because of aluminum.
Yes.
Okay, please go ahead.
Some musculoskeletal system, there is no bony deformity or abnormalities were noted. On spine examination, on inspection, no scars, sinuses, or swelling over the spine. On palpation, no tenderness noted on palpation. The intervertebral spaces were well appreciated. Sir, my provisional diagnosis is 40 years old female, known case of systemic hypertension and hypothyroidism with chronic renal failure on dialysis thrice a week and planned for renal transplant.
Okay. So, anything else which will be important for us as anesthesiologists in the neurological symptom? The patient is diabetic or no?
No, sir.
So, suppose even if the patient was diabetic, so there is another concern which becomes challenging in such patients in the neurological system.
Sir, autonomic neuropathy.
And?
So, autonomic neuropathy and peripheral polyneuropathy, sir.
So, autonomic neuropathy, can it occur in a patient of CRF without having a diabetic mellitus?
Yes, sir. It can occur because of uremia.
So it is important to know this. Okay, so we have a case who has CRF on dialysis with comorbidities like hypertension and hypothyroidism.
Yes.
What are the concerns before we go to investigations? What are the concerns that will come to your mind when you kind of do a PAC of such a patient and we post him for
Sorry, sir. Concerns for this patient.
anesthesia concerns for this patient?
Okay. Sir, my concerns will be patient related, anesthesia related, and surgery related. For patient related concerns, since my patient is already having comorbidities, I would like to optimize hypertension and hypothyroidism. My patient will be having anemia, so I will optimize. My concern is to optimize anemia preoperatively. Sir, after that, my patient is on dialysis, chronic dialysis. So, optimization of dialysis pre-op is a concern of mine. Sir, these patients have renal osteodystrophy. So, positioning will be a concern, and care of AV fistula. Sir, in anesthesia related concern, metabolism and excretion of my anesthetic drugs and also protein binding of my anesthetic drugs will be altered. That is a concern. Sir, after that, in surgery, in surgical concerns, it is ischemia time, both warm ischemia time and cold ischemia time.
So what is warm ischemia and the cold ischemia time?
Sir, warm ischemia time is further divided into donor warm ischemia time and recipient warm ischemia time. Donor warm ischemia time is the time from the clamping of the vessels till the time kidney is submerged in the preservative solution. And the recipient warm ischemia time is from the time that kidney is taken out of the preservative solution till the time there is unclamping of vessels.
Okay. So how much is the time usually?
Sir, it should be less than half an hour.
Okay. And what about cold ischemia time?
Sir, cold ischemia time is the time from the time in the preservative solution.
Okay. So what is the preservative solution that is usually used and why it is important to know?
Sir, there are three preservative solutions. There are Eurocollins, University of Wisconsin, and HTK solution, which is histidine, tryptophan, alpha ketoglutarate solution. Sir, most commonly used solution is University of Wisconsin solution, and it is composed of so the colloid is hydroxyethyl starch. It contains inert substances like lactobionose and raffinose, scavengers such as glutathione and allopurinol, and sir, the energy source is adenosine. It is high in potassium.
Okay, good. So we know the concerns, and based on our history examination and anesthetic concerns, now we have to the patient has come for a pre-anesthetic checkup, and we have to write the investigations what this patient should be undergoing. So what
Sir,
are the
in investigations, I would like complete blood count, including hemoglobin, total leukocyte count, and platelet count. Sir, I want a kidney function test, including blood urea, nitrogen, and creatinine, and serum electrolytes, including sodium, potassium, calcium, magnesium, and phosphate. Liver function tests, including serum proteins, especially albumin. Sir, then because my patient is a known case of hypothyroidism, I also want the thyroid function test to be done. Sir, coagulation profile, including bleeding time, clotting time, PP and INR. Sir, after ECG, chest X-ray, 2D echocardiography, ABG, and blood sugar, and viral markers.
Okay. So what? So this patient had a platelet count of say about 1.5 lakh, and coagulation test we did, it was normal. So will you be still worried even if the count is normal in such patients?
Yes, sir. Because of uremia, these patients have a qualitative dysfunction of platelets, and even if my platelet count is normal, the clotting process can still be deranged.
So what else we can do to be further assured that the function is normal and we can
The platelet function can further be assessed by doing thromboelastography.
so what are the tests you will do? What are the times, various times, and how is the graph which is there, which is normal? How do you know it is a normal function on a thromboelastography?
Sir, we see 5 parameters on a thromboelastography. First is reaction time or R time. Second is kinetic time or K time. Third is alpha angle. Fourth is maximum amplitude achieved. And fifth is lysis time, which can either be at 30 minutes or 60 minutes. Sir, normally it is a bell-shaped curve, and for platelet function, we see maximum amplitude. Maximum amplitude should be in the range of 50 to 70 centimeter. If it is less than that, then it indicates platelet dysfunction.
Okay, so if the count is normal and the function is normal, we can actually go ahead with whatever techniques we want to use as anesthetics for pain management.
Yes.
Okay. So now we have done these investigations and grossly they are normal. So the hemoglobin was about 8, creatinine was 3.
Yes.
So rather it was, and what was the last dialysis the patient had?
So last dialysis was 2 days ago when the patient came to PSC for checkup. Pre-operatively, I want the last dialysis to be within 24 hours and it should be heparin free. And the ultrafiltrate removed should be such that the patient is 1 kg above his dry weight.
So how do we know what is the dry weight of the patient?
So dry weight of the patient is the weight of the patient after a successful dialysis.
So what was the dry weight in this patient? Do we know? Do they write properly on their sheet? How do we know?
Sir, it is written on the nephrology sheet.
We have to just see what is the dry weight and we have to be closer to that before surgery. Okay. So now this patient has come for surgery for a renal transplant, and it is who is the donor in this patient?
Sir, her husband.
Hmm?
Her husband is the donor.
So usually we do a live related donor, and this patient has been posted for surgery. So before we proceed further, no, there's a small question. So how do we actually stage chronic renal disease for completion's sake and for examination purpose? Or do we?
Sir, KDOQI stages chronic kidney disease into 5 stages. Stage 1 is where there is an insult to the kidney, but there is a normal GFR. That means GFR is more than 90 ml per minute per 1.73 meter square. Stage 2 is with mild reduction in GFR, which is 60 to 89 ml per minute per 1.73 meter squares. Stage 3 is moderate reduction, which is 30 to 59. Stage 4 will be severe reduction, which is 15 to 30. And so stage 5 is end stage renal disease, which is GFR less than 15 ml per minute per 1.73 meter square.
Okay. So when do we actually end up starting a dialysis in a patient?
So dialysis is usually started when GFR falls below 20.
Okay. Say 15 to 20. So now
15 to 20.
Okay, so now this patient is posted and we have a live related this thing, and I'm sure the organ donation related checklist has been done as per the institution protocol. So that you have to be really sure that the patient is on actually a live related and all the papers are in place before such patient is taken up for the medical legal purposes. Okay, so now this patient is now wielding the theater and you are the chief anesthetist there to manage a recipient in a renal transplant patient. So what are the monitors you would like to connect in this patient? Hello? I think it's the Priyanka. Can you hear?
Sir,
There's some
For monitoring, I would like to do pulse oximetry, ECG. Yes, sir.
हाँ, थोड़ा आवाज आपकी ना कट कट के आ रही है. I'm not sure about.
Hello.
Am I audible?
Okay, sir. Yes, sir. Yes, sir. You're
आपकी आवाज थोड़ी ना कट कट
audible.
के आ रही है.
Sir, I'll just check. Sir, am I audible now?
हाँ, आप अभी तो ठीक है, पर बीच बीच में खराब हो जाती है एक्चुअली.
Okay, sir. Sir, for investigation, I would for monitoring, I would like to do pulse oximetry, ECG, non-invasive blood pressure monitoring, followed by invasive blood pressure monitoring in the limb opposite to the AV fistula. Sir, then end-tidal CO2 and temperature monitoring, I will start after induction. So neuromuscular monitoring, then sir, CVP monitoring, CVP monitoring, urine output, ABG, blood sugar.
Okay. Can you just repeat the monitoring? I just missed. There's some technical glitch. So you said pulse oximetry.
Pulse oximetry, sir, ECG, sir, non-invasive blood pressure followed by invasive blood pressure monitoring on the limb opposite to the site of AV fistula. Sir, after neuromuscular monitoring, urine output monitoring, temperature and end-tidal CO2 monitoring, I will start after my induction is done. Sir, blood sugar and ABG monitoring.
Okay, so you wish to start the temperature and urine output after induction?
Temperature and end-tidal CO2 post-induction.
Temperature, okay, okay. Okay, now what are the drugs you want to prepare? So we missed one thing. Before we start doing the PAC, we have to write the PAC orders as well. So since we are just starting. So what are the PAC orders in such a patient which should be written when you are seeing in the clinic?
Sir, during the PSC, I will explain the procedure to the patient and take a high risk written informed consent. I will advise the patient NPO for 8 hours. I will, sir, ask the patient to continue all antihypertensive medications and thyroid medications. I will give the patient.
So suppose the patient was on ACE inhibitor, you should still like to continue that, or you wish to?
Sir, if the patient if after dialysis the patient has a BP less than 130, then I would omit the morning dose of ACE inhibitors because they can cause profound hypotension intraoperatively.
Okay, okay.
Sir, I will give anxiolysis to my patient with the tablet Alprazolam 0.25 milligram. I will give anti-aspiration prophylaxis with tablet metoclopramide 10 milligram and tablet ranitidine 150 milligram night before surgery. Sir, after that, I will ensure that there is a high HDU bed or a dedicated renal transplant unit bed available for this patient for post-op monitoring. Sir, I want investigations post-dialysis, which will include complete blood count, ABG, kidney function test, and serum electrolytes.
And now we come back to the OT theater. So now we have posted this patient and we have put on the monitors. So what are the drugs we wish to use for anesthetizing this patient?
Sir, I'll prepare all my emergency drugs, and sir, then my induction and muscle relaxants. Sir, I wish to use for pre-medication, I wish to use injection midazolam and injection fentanyl. For induction, I want to use propofol, and for muscle relaxation, I want to use atropine.
Okay. So any other choices for induction agent and muscle relaxation we have? Suppose we don't have atropine. So what are the other options which we have? Similarly with the propofol.
Sir, apart from propofol, I can also use thiopenton or etomidate if I have. Sir, with thiopenton, I'll have to give it in titrated doses because in these patients, volume of distribution is increased. Sir, etomidate also I can use similarly in titrated doses.
What
Sir,
about
with
muscle?
respect to muscle relaxant. So with respect to muscle relaxants, if I don't have atracurium or cis-atracurium, I can use vecuronium, but in very titrated doses with neuromuscular monitoring.
So what is peculiar about the effect of muscle relaxant in these patients? Suppose we don't have cis-atracurium or atracurium and we end up using vicuronium bromide. So what are the initial doses with respect to normal patient, and how do we actually decide on the further top-up doses of muscle relaxant?
Sir, initial dose will be like 0. For vecuronium, initial dose will be 0.1 milligram per kg only, but subsequent doses are to be significantly reduced because the clearance of vecuronium, 30% clearance is by kidney. So the metabolite will keep on accumulating. So the dosing, so the dose as well as the frequency of giving muscle relaxant needs to be increased.
Okay.
Dose needs to be reduced and frequency needs to be increased.
So, but you said the volume distribution is on the higher side, so you may end up giving a more dose initially because the drug will be distributed to a larger area, and the effect may not be normal with the usual doses, which is 0.1 milligram per kg we use for vicuronium. So you may have to initially give a higher dose, and yes, subsequently you have to be careful. Ideally, do not use it. If you don't have a choice, then you will have to do a neuromuscular monitoring. So in neuromuscular monitoring, what is the parameter you usually judge for assessing the need for a stop-up dose, and how do you assess the recovery from a neuromuscular relaxant?
Sir, we use strain of 4 TOF ratio. Sir, if the TOF ratio is more than 0.7, then we give a top-up.
Oh, no. Actually,
No,
so we give a top-up when we have 1 or 2 ticks. So in TOF means, strain of 4 means there are 4 stimulus and there are 4 responses. So if we get 2 response, 1 or 2 response, depending on the depth and the muscle relaxation the surgeon is needing and the patient is requiring, you will give the top-up. And for recovery, it is 0.9 and up to 1, some people say it is not 0.7. So there are all the 4 responses, and the 4th one is closer to 1, the first one. The ratio between 4th and the 1 will be 0.9 or more. So that is about time we'll try to reverse this patient. Okay. So now we have this patient and what about inhalation agent? Any specific choices?
Sir, desflurane, mixture of air, nitrous and desflurane. If my patient has pulmonary artery hypertension, I will avoid nitrous oxide and use air instead. And if I don't have desflurane, then I will use isoflurane.
Okay. So why not sevoflurane?
Sir, because at low flows, sevoflurane forms compound A on reacting with soda lime, so which is nephrotoxic.
Okay. So now we have given muscle relaxant, and the patient has been started, and we give induction agent, we give fentanyl, and the induction goes fine. And another important thing while induction, you should be careful. Patient is hypertensive.
AV fistula, sir. I need to be careful about padding and covering AV fistula.
Okay.
And sir, because my patient is hypertensive, and these patients are also post-dialysis prone to hypertension, hypotension, my induction agent should be given in slow and titrated doses. Sir, secondly, they have a very strong intubation response. So I would like to blunt that intubation response by giving injection lignocaine 60 milligram, which is 3 ml, preservative-free lignocaine 90 seconds before intubation.
Okay. So what is the most important thing for blunting the intubation response?
Sir, that the duration of laryngoscopy is reduced to less than 15 seconds.
So you should be really careful. And regarding this induction of this patient. Do you prefer to use a standard induction technique or a rapid sequence, and why?
Sir, if my patient has symptoms of uremic gastropathy, upper GI bleed, and such history, in such patients, gastric emptying time will be increased. So they are prone to aspiration. If my patient has such symptoms, then I would like to use rapid sequence induction. If these symptoms are absent, then I can proceed with the atracurine.
Okay, so if you do a rapid sequence, so do you wish to change your muscle relaxant, or you still go ahead with vicuronium or etraquarium?
Sir, if I will first check the potassium levels of my patient, if and also the whether the patient has difficult airway or not. Sir, if the potassium level is less than 5.5 milliequivalents per liter, I will use succinylcholine. And if it is more than 5.5, then I will use rocuronium in high dose, in high induction.
Okay. So now another important thing in this patient will be analgesia, and we had discussed about neuropathy and presence of platelet dysfunction. So what are the modalities of analgesia you wish to use in this patient?
So for analgesia, I will use opioids, which is IV fentanyl. Sir, IV paracetamol injection I can give. I will avoid non-steroidal anti-inflammatory drugs because they can cause they can further cause platelet dysfunction. Sir, other than that, after if my platelet count and thromboelastography is normal and the last dialysis was heparin free, then I can use epidural. If not, then sir, I can also you go for blocks, which will be transverse abdominal plane block and quadratus lumborum plane block.
So you must be aware, we'll not go into details because time is running. So about the nerve supply of kidney and what are the dermatomes which are involved, and that will help you to select the right block and the right level. Okay, so now this patient, the surgery is going well and the donor has given the kidney, and now they have surgeons have removed the damaged kidney and they have transplanted the new one. So what is the most important thing you should be aware while the kidney is being transplanted into the patient?
Sir, I have to avoid hypotension and hypovolemia, and I should ensure adequate renal perfusion during this time. And also the immunosuppressants that I will be giving intraoperatively, they should be given half an hour before starting anastomosis.
So how do you ensure perfusion in such a patient? Good perfusion
Sir,
without having...
sir,
Okay.
yes. Sir, 30 minutes before this venous, when the venous anastomosis is going on, I will give injection mannitol 0.5 milligram per kg over 30 minutes. And when to expand intravascular volume and for osmotic diuresis. And sir, after venous anastomosis is done and halfway through arterial anastomosis, 15 minutes before unclamping, I will preload my patient with a balanced salt solution. We use 0.9% normal saline. In the we give the, goal-directed fluid therapy to maintain a CVP of 15 centimeter of water or systolic blood pressure of 130 millimeter of mercury or mean arterial pressure of 90 millimeter of mercury. Usually 2 to 3 liters of fluid bolus is given at this time.
And
Before unclamping.
If you have to start a vasopressor to maintain the blood pressure, what will be your choice for that?
Sir, I will avoid vasopressors with alpha activity because they cause the renal artery vasoconstriction. My drug of choice would be norepinephrine.
Okay, and what else?
Sorry, sir.
What else? If norepinephrine suppose is not there, then any alternative we can use?
So dopa is dopa maybe it's not advised to use dopa, but
Okay, chalo, theek hai. So now this patient is doing fine, and we had a good analgesia. We had not started on any epidural or any other block, but we had decided to use a opioid-based analgesia, and so the patient is very kind of demanding, and he is very uh, cranky. He wants very good analgesia. So what is the method of opioid delivery you will use with such a patient?
Sir, I can go for patient control anesthesia with fentanyl.
So what is PCA, and what are the parameters you set in a PCA pump?
Sir, PCA pump is a pump that has a basic infusion rate and a bolus with the lockout interval. So we set the parameter of the background infusion, which for fentanyl is 0.5 to 1 microgram per kg per hour. Sir, then we set a bolus, which is usually 10 micrograms for fentanyl, and a lockout interval of 10 to 20 minutes. That means if the patient re-pushes the button for a bolus in the lockout interval, it will not deliver any bolus.
Okay, good. So what are the immediate post-operative complications which, as an anesthetist, we must know and should be prepared for?
Sir, immediately post-operative, I have to ensure that there is adequate urine output. Sir, after bleeding. Sir, immunosuppressant, there can be anaphylactic reaction to immunosuppressants. I need to be cautious of that. And if there is adequate urine output and all the other extubation criteria are met, I will extubate the patient and transfer the patient to HDU or renal transplant ICU. Sir, there I need to be very strict about monitoring of urine output, ECG changes, and serial ABGs. If there is any acidosis or imbalance, electrolyte imbalance, I need to be cautious of that.
Oh, good. So the timer which is coming on the screen is correct, or so we have about 20 minutes left? Nitin?
Yes, sir, 20 minutes.
Okay, chalo, theek hai. So now so Priyanka, you have done well, and for summarizing the topic, we'll have just a minute. So Dr. Meena will summarize the topic for the students. We can go on, and it is not that every time the Viva will go the same way. So it all depends what do you speak in the exam. So whatever you give a history and whatever answers you give for the questions, the next question usually is on that. So mostly the Viva is in the hands of the students. And believe me, the examiners are not as well read as students on the exam day. So they may have more experience, but the students are better read for the day. So be careful when you speak, and try to focus and don't speak too much. You have been very precise in speaking, and this is the way to kind of handle the exam. And if you are not sure, it is better to say that you don't know, rather than committing to the wrong answer and adding and then falling into the soup. So that should be avoided. So over to you, Meena, for summary. We have about 20 minutes.
म्यूट हटा दिया है. Good morning. Thank you, sir, and thank you, Priyanka, for this wonderful discussion. Now I will briefly summarize my case, that is anesthesia for renal transplant. So case summary, our patient is 40-year-old female, known case of chronic renal failure on dialysis thrice a week with systemic hypertension and hypothyroidism, planned for renal transplant. So before proceeding with the management of the case, I would like to throw some light on physiological peculiarities and pathophysiology of CKD, because it will make you understand anesthetic management in a better way. So renal blood flow is 20 to 25% of the cardiac output, out of which 80% is to cortical nephrons and 20% is to medullary area. Autoregulation of the renal blood flow occur at mean arterial pressure of 80 to 180 millimeters of mercury. So KDOQI guidelines proposed a 5-stage classification for CKD and defined CKD as GFR of less than 60 ml per minute per 1.73 meters square for more than 3 months, where there is any evidence of kidney damage, or evidence of kidney damage for more than 3 months based on pathological specimen, imaging, or laboratory tests like proteinuria, irrespective of the GFR. This is the 5-stage classification given by KDOQI. Now comes to etiology of CKD. The most common cause of CKD is diabetic nephropathy, which is closely followed by systemic hypertension. Other causes are glomerular disease, interstitial diseases of the kidney, vascular diseases of the kidney, and inherited diseases of the kidney. Pathophysiology of chronic renal failure is very important because it will help you to manage your CKD case very well. So in CKD, there is sodium and water retention. Because of the sodium and water retention, there will be increased in intravascular volume. And because of the sodium water retention itself, there will be hypertension. So both these factors, hypertension and increased intravascular volume, can lead to heart failure and edema. That is very common manifestation of CKD. As you all know, in CKD, there is decreased secretion of potassium. It will lead to hyperkalemia. Since there is decreased elimination of the nitrogenous waste, it can lead to uremia, and uremia itself has very fatal consequences like coagulopathy, which is very important for anesthesiologists, pericarditis, and other manifestations of uremia are impaired immune function, skin disorders, gastrointestinal manifestations like uremic gastroparesis, neurological manifestations like uremic encephalopathy, and sexual dysfunction. In CKD, there is decreased production of erythropoietin that can lead to anemia, and anemia itself is multifactorial in CKD, and I will explain it in further slides. In CKD, there is decreased secretion of hydrogen ions, and most of the body's bicarb is utilized to neutralize this hydrogen ion. So it can lead to acidosis, and acidosis itself has very fatal consequences like myocardial depressions, skeletal muscle wasting, and altered oxygen delivery. In CKD, since there is a decreased there is decrease in activated form of vitamin D. So there will be, and vitamin D helps in calcium absorption. So this lead to hypocalcemia, as well as there is decrease in elimination of phosphate. So there is hypophosphatemia. Both hypophosphatemia and hypocalcemia leads to secondary hyperparathyroidism in CKD, which is very commonly seen in CKD. And these lead to renal osteodystrophy. This is important because these CKD patients are prone for fractures because of this osteodystrophies. Now come to cardiovascular system. As I have already discussed, systemic hypertension is very common in CKD patients because of the sodium and water retention, as well as there is altered renin-angiotensin secretions. Congestive heart failure itself manifests because of the fluid overload in CKD, as well as uremia itself can lead to uremic cardiomyopathy and consequently congestive heart failure. In CKD, there is a decreased secretion of triglyceride. So these patients are particularly prone to develop atherosclerosis and ischemic heart disease. So, uremic pericarditis and cardiac tamponades are other manifestations of CKD. These patients are prone for arrhythmia because of the hyperkalemia and hypocalcemia. In hematological system, as I have already discussed, anemia in CKD is multifactorial. There is decreased production of the erythropoietin. In uremia, there can be ulcers in GI system, so blood loss is there. Hemodilution and loss in every dialysis. Bone marrow suppression is other common cause of anemia in CKD patients. Platelet dysfunction is very common in CKD because of the uremia. So platelet count can be normal, but platelet function is not normal, which can be assessed by thromboelastography. Leukocyte dysfunction is there, so these patients are more susceptible to infection. In pulmonary system, because of the volume overload, these patients develop interstitial edema and alveolar edema. And this is important to us because of the interstitial edema and alveolar edema, there is VQ mismatch. So there is risk of hypoxemia. And these, since these patients are in metabolic acidosis, so usually these patients are hyperventilating. And CKD itself is an inflammatory process. So there is increased permeability of alveolar capillary membrane. So it leads to pleural effusion. In neurological system, there is peripheral neuropathy and autonomic neuropathy, due to which there can be delayed gastric emptying, postural hypotension, and that is very important to assess before proceeding with anesthetic management, silent myocardial ischemia, and other dialysis related problems like dialysis dementia and disequilibrium syndrome. In endocrine system, these patients develop peripheral insulin resistance secondary to hyperparathyroidism. These patients are very prone for metabolic bone disease and fractures because of hyperparathyroidism, as well as there is accelerated atherosclerosis. In metabolic derangements, metabolic acidosis is most common in these patients. Hyperkalemia is other important manifestations and important for anesthesiologists, as you have to manage hyperkalemia before proceeding with surgery. And calcium phosphorus derangements I have already discussed in previous slides. In gastrointestinal system, since these patients have autonomic neuropathy, so there is delayed gastric emptying. So these patients are prone for aspiration, and RSI may be required in these patients. So from above discussion, now we have come to conclusion that our key perioperative issues are anemia, neuropathy, hypertension, electrolyte imbalance, hypervolemia, gastroparesis, metabolic acidosis, coronary artery disease, and platelet dysfunction. So before proceeding with the management of CKD patient, I want to throw some light. I would like to throw some light on dialysis, because dialysis is very important aspect for anesthesiologist. So what are the indications of dialysis? Any worsening clinical state, overhydrated state like congestive heart failure, hypertension, and increase in weight is indication for dialysis. Any neurological sequelae like uremic encephalopathy, pericarditis, these are indications for dialysis. In biochemical parameters, whenever there is rising trend of potassium for more than 0.5 milliequivalent per liter per day, there is rise of serum creatinine more than 1 mg/% per day, there is increased in blood urea nitrogen more than 20 mg/% per day. These are biochemical indications for dialysis. Blood urea of more than 200 mg/%, serum creatinine of more than 10 mg/%, and potassium of 7 milliequivalent per liters are definitive indications for dialysis. So what are some extra considerations in dialysis? So last dialysis should finish at least 12 to 24 hours prior to surgery. And some case report indicates that you should avoid dialysis in last 24 hours because cases has been seen there is increased chances of graft rejection if last dialysis is done within 24 hours. And if dialysis is done within 24 hours surgery, there can be fluid depletion, redistribution, electrolyte disturbances, like hypokalemia is very common after dialysis, and residual anticoagulation from heparinization is common after dialysis. So if it's possible, last dialysis should be done heparin free if it is done within 24 hours of surgery. In dialysis, you should avoid excessive ultrafiltration if hemodialysis is necessary for fluid removal on the day of the surgery, and it should be heparin free. If excessive ultrafiltration is done, it can lead to intravascular volume depletion, and it can lead to more intraoperative hypotension, which is not desirable in any CKD case management, because renal perfusion is our goal of maintenance of renal perfusion is our goal of management. If heparin is used, you should wait at least 4 hours before proceeding with the surgery, because half-life of heparin is 90 minutes. And before proceeding with the surgery, you have to check PTT. It should be less than 45 seconds at the time of surgery. You should target a post-dialysis weight that is 1 to 2 kg above the patient's usual dry weight. And what is dry weight? Dry weight, there is no particular definition of dry weight, and it is decided by the nephrologist what is the adequate dry weight for that patient, target dry weight for that patient. So dry weight is defined as the lowest weight that is tolerable to a patient without symptoms or occurrence of hypotension. So if I have to summarize dialysis related problems, these will be hypovolemia with electrolyte abnormalities, coagulation abnormality because of the heparinization, dialysis disequilibrium syndrome, peritonitis in case of peritoneal dialysis, and dialysis dementia. Now comes to the anesthetic management of the CKD patient. So before proceeding with the case, we should know what are the concerns in any CKD patients. So you have to divide your concerns in 3 categories with patient-related concern, anesthesia-related concern, and surgery-related concern in any surgery. So in our patient-related concern, our patient is having comorbidities like hypertension and hypothyroidism. So we should also deal with the concerns specific to that particular disease. Others patient may have other manifestation, other diseases like diabetes mellitus, autoimmune disease. And as I have already discussed, these patients are very prone for ischemic heart disease, coronary artery disease, as well as there is reduction in ejection fraction. That is additional challenge in anesthetic management for these patients. These patients are immunosuppressed, so strict aseptic precaution has to be taken during handling of these patients in OT table. So now what are the anesthesia related concerns for these patients? Since these patients are having uremic gastroparesis, these patients are more prone for aspiration. So some patients may need rapid sequence intubations in these patients. So there is difficult IV access in these patients because of the multiple dialysis and multiple cannulations beforehand. There is increased hemodynamic response to laryngoscopy in these patients because these patients have autonomic neuropathy as well as increased sympathetic stimulation, and because of the comorbidities like hypertension and diabetes mellitus. Once the induction is done, these patients are also very prone for refractory hypotension because these patients have autonomic neuropathy, plus these patients are on ACE inhibitors and ERBs. So refractory hypertension is one major concern in these patients because it will compromise our renal blood flow. These patients are on repeated hemodialysis. So there is increased volume of distribution. So there is a alteration in drug dynamics. So you have to choose your drug dose wisely in these patients. And because of renal osteodystrophy, there is increased risk of fracture. So whenever you are handling a case of CKD, you have to be very careful while positioning or while shifting the patient to trolley to table, OT table. You have to take due care of AV fistula. Please apply no BP cuff, no IV line, no arterial line on AV fistula hand. You have to pad it with cotton and label it as AV fistula hand, and nothing to be used on this hand. Other concerns are dialysis related problems and delayed emergence because of the decreased excretion of anesthetic drugs in these patients. In surgery related concerns, prolonged warm ischemia time due to technical aspect of the surgery is concern. Blood loss is rarely seen in these patients, but because surgery is near major vessels, so blood loss can be expected in some cases, but it is very rare. So now comes to ischemia time. It is the duration for which the blood supply to the organ is interrupted. Donor warm ischemia time, recipient warm ischemia time. So donor warm ischemia time is time from clamping of aorta or renal artery of the donor to the time kidney is flushed with cold preservative solution. In recipient warm ischemia time, time from which the kidney is taken out of the cold preservative solution to the time it is reperfused by the recipient blood is that till the venous anastomosis is complete. Cold ischemia time is the time for which the kidney stays perfused and submerged in cold preservative solution. Now, investigation and optimization for this CKD patient. You will ask for CBC to see hemoglobin, platelet count, and total leukocyte count in these patients. Since these patients are very prone for qualitative dysfunction of platelet due to uremia, it can be further confirmed by thromboelastography. Kidney function test, electrolytes are important because usually these patients have hyperkalemia, but after dialysis these patients can also have hypokalemia. So post dialysis electrolyte, KFT and CBC is required in these patients. Other investigations are LFT and serum protein. These patients are usually have hypoalbuminemia and so on, low oncotic pressure, which leads to various manifestations of fluid overload in these patients. Coagulation profile is important. Chest X-ray to rule out any pleural effusion, cardiomegaly, and other sequelae. In ECG, you can see signs of ischemia, arrhythmia, left ventricular hypertrophy, any conduction block, and manifestations of hyperkalemia. 2D echocardiography is required in these patients to see left ventricular hypertrophy, ejection fraction, any regional wall motion abnormality, pericardial effusion, pulmonary artery hypertension, or any regurgitant lesion if present in these patients. Other investigations which are important are RBS, parathyroid hormone, because secondary hyperparathyroidism is common in these patients. Urine analysis, and nowadays COVID-19 RT-PCR plus ABG. Additional investigations are blood type compatibility and HLA typing. Cross-matching of 2 units of packed cells, since significant blood loss is a possibility in any surgical procedure involving ligation and re-anastomosis of the major blood vessels. So in pre-op optimization, you have to correct anemia. Anemia can be corrected by erythropoietin. Erythropoietin is to be initiated when HB is less than 10 gram per deciliter. The optimal target of hemoglobin level for CKD patient is not well defined. It is usually 8 to 10 gram per deciliter, and some places it is mentioned at 10 to 12 gram per deciliter. If your patient is hypertensive, mostly all the patients of CKD are hypertensive. 80% of the population with CKD is hypertensive. So you have to control hypertension before surgery. Look for the need of pre-op hemodialysis and optimize fluid and electrolyte imbalance in these patients. Correction of acidosis is an important aspect. Reduce blood urea nitrogen to less than 100 milligram per deciliter if possible. And the routine dialysis should be avoided in less than 24 hours prior to transplantation, as it increases the risk of delayed graft function. In anesthesia management, pre-medication, aspiration prophylaxis with H2 blockers to be given. Injection metoclopramide or tablet metoclopramide 10 milligram to be given 20 minutes prior to anesthetic induction. Immunosuppression to prevent graft rejection is commenced in the pre-operative period. So what are all monitors you will attach to this patient? ECG, saturation, BP and temperature are the common monitors applied in these patients. Plus, you have to take invasive line in these patients to see CVP and arterial BP, invasive arterial BP. Some article mentions that there should be very high threshold for arterial BP monitoring. So you should avoid upper limb arteries, because if in any case there is graft rejection, these arteries may be required for future AV fistula. But in our institute, it is common practice to put invasive arterial BP monitoring and CVP. Addition to that, it is wise to use neuromuscular monitoring in these patients, as there are one of the concern of anesthesia in these patients is altered drug dynamics. Additionally, end-tidal CO2, urine output, and agent analysis and inhaled fraction of oxygens are other common important monitoring used in these patients. You should avoid putting CVP line on the same hand with AV fistula. This is one reference which is showing arterialization of the central venous pressure waveform from a peripheral arteriovenous fistula. You can see there is arterialization of the CVP line, so it can give a false reading. So whenever possible, you should avoid putting CVP line on the same hand with AV fistula. So what is our plan of management? Our plan of management is general anesthesia with endotracheal intubation and plus minus epidural analgesia as per the coagulation profile of the patient. Induction drugs should be given slowly to minimize drug-induced hypotension in these patients. So before proceeding with the induction of this CKD patient, you have to understand some clinical implications in these patients related to drug metabolism. Since these patients are with increased volume of distribution, because they have increased volume, intravascular volume, so there is increased volume of distribution. So you may need larger initial dose to produce neuromuscular blockade in these patients. But since these patients also have reduced metabolism and excretion of drug because of CKD, so the dose of drug required during maintenance dose is reduced. So it is wise to use neuromuscular monitoring in these patients whenever you are using long-acting neuromuscular blockers in these patients. But in case of atracurium and cis-atracurium, the dose required to maintain block, there is not much change in the dose of atracurium and cis-atracurium. So induction, preferred agent for induction in these patients is still propofol at the dose of 1 to 2.5 milligram per kg, because pharmacokinetic and pharmacodynamic response to this agent is not markedly altered in end-stage kidney disease. After induction of these patients, you have to blunt hemodynamic response to laryngoscopy in these patients, because you don't want any sympathetic stimulation in these patients, because if there is any sympathetic stimulation in these patients, it will lead to vasoconstriction of renal blood vessels, and it will further reduce your renal blood flow. So give injection lidocaine 1 to 1.5 milligram per kg 90 seconds before intubation. Additionally, injection fentanyl 1 to 2 microgram per kg to blunt this hemodynamic response to laryngoscopy in these patients. You can use other drugs also like esmolol, nitroglycerin, and metoprolol to blunt hemodynamic response. So when it comes to muscle relaxant, the choice of muscle relaxant is cis-atracurium or atracurium, because these neuromuscular blocking agents are metabolized through non-specific esterases, mediated hydrolysis, and a non-enzymatic pH temperature dependent degradation called Hoffman elimination. Whenever possible, you should avoid long-acting muscle relaxants like pancuronium. And in case if you are using vecuronium, rocuronium, you should use neuromuscular monitoring in these patients. That is must. During maintenance phase, you have to maintain anesthesia with oxygen, air, or nitrous you can use if patient is not having any pulmonary artery hypertension. So inhalational agent of choice is still isoflurane and desflurane, but you can use sevoflurane at a fresh gas flow of more than 1 to 2 liter. It is advisable not to use sevoflurane at low flows. US Food and Drug Administration recommend using fresh gas flow of more than 1 to 2 liter per minute to administer sevoflurane in these patients, because at low flow anesthesia, there will be formation of compound A, which will be nephrotoxic. So now analgesia for these patients. In analgesia, you can use multimodal analgesia. And if patient is not having any coagulopathy, you can use regional blocks like epidural anesthesia, paravertebral block, and transversus abdominis block is commonly used in these patients. Other blocks are quadratus lumborum block and erectus spinae block. And you should avoid any nephrotoxic drug like NSAID in these patients. So fluid management in these patients are very important, because one of the major goal of CKD patient management is to maintain renal perfusion. So our main anesthetic goal is to maintain adequate renal perfusion, as graft function depends mainly on renal perfusion. Any isotonic balanced electrolyte solution can be used in CKD patients. There is no consensus which fluid is best for renal patient management. But there are some studies which shows that whenever you are using normal saline for more than 2 to 3 liters, that can result in hyperchloremia, hyperchloremic metabolic acidosis, renal vasoconstriction, decreased glomerular filtration rate, and kidney injury. But you should also avoid potassium containing fluid. So the best option is you can use normal saline altered with ringer lactate, or you can use other fluids like normazole plasmalite, which are isotonic balanced solutions. Blood transfusion should be avoided if possible, but if it is necessary, when HB is less than 7 gram per deciliter, particularly if surgical bleeding is ongoing, then use only salvaged autologous washed RBCs or leukocyte reduced RBC in these patients. So now what are the various measures to enhance urine output in these patients? Two common agents used in these patients are diuretics and furosemide. So, mannitol and furosemide. So 20% mannitol in doses of 0.5 gram per kg 30 minutes prior to unclamping is usually given in these patients. So mannitol induces osmotic diuresis, and it expands intravascular volume because it has high osmolarity. It decreases the incidence of acute tubular necrosis. It works as a free radical scavenger, and it enhances the release of vasodilatory prostaglandin in kidney. Furosemide, it decreases renal oxygen consumption by inhibiting sodium-potassium ATPase, but its role is controversial because it disturbs the protective corticomedullary redistribution of blood flow. But studies, there is no particular study, there is very scanty evidence regarding these two agents, whether these two agents prevent any acute tubular necrosis in these patients or not. So many of the major institutes are not using these two agents regularly in CKD case management. So now what should be our hemodynamic goals in these CKD patient during renal transplant? We should maintain our central venous pressure for more than 12 to 15 millimeters of mercury. Systolic blood pressure should be more than 130 millimeters of mercury. Mean arterial pressure should be more than 80. And the total IV fluid of at least 30 to 50 ml per kg per hour can be used. And stroke SVV should be less than 15%. You should avoid hypoxia, hypovolemia, hypotension, acidosis, and hypothermia, as well as use of any nephrotoxic drug in these patients. During reversal, stress response associated with extubation should be attenuated, like during laryngoscopy. So you can again use lidocaine or esmolol or any other agent to attenuate these stress response during reversal. You should slowly administer the reversal agent, because and inadequate reversal of neuromuscular blockade is a potential problem in these CKD patient. Extubate your patient when your patient is fully awake and obeying commands. In post-operative period, continue your monitoring in ICU or HDU. Continue monitor ECG to detect any cardiac dysarrhythmia related to hyperkalemia. Measure urine output to detect early graft rejection in these patients. Adequate analgesia to be maintained in these patients. Supplement these patients with oxygen and immunosuppressant therapy to continue. Thank you.
Thank you, Dr.
Thank you, ma'am.
Sir, we have 2 questions in the chat box.
Namita, बताओ क्या
Anji,
questions
sir,
हैं?
the first question is, sir, whether AC inhibitor in case of renal transplant surgeries
Very good question.
can be. Sir, can you hear me?
I can hear you.
Yeah. The question is whether AC inhibitors in the case of renal transplant surgery should be continued as discussed in the case.
So now, so you have a student. The student is logged in.
Yes, sir. In delegate link, they have logged in.
Okay, okay. नहीं हमारा presenter है भी नहीं है प्रियंका. So we had discussed.
I'll just.
Okay. So we had discussed in the case, and Priyanka rightly said, so it depends on the blood pressure. Mostly as a dictum, we should stop ACE inhibitors generally because they tend to have accelerated hypotension during the surgery. So especially if the blood pressure is borderline, it is a good idea to stop it preoperatively and continue with the case. So we had discussed this in the case
Priyanka is
also.
logged in now.
Priyanka has mentioned the blood pressure. So if it is less than
pressure is less than 130, we should omit ACE inhibitors.
So that is the case. And there is one more question on blood transfusion we had somehow missed in the discussion. So we should understand that these patients are undergoing a transplant and they can we start with immunosuppression, and giving a blood transfusion patients can be tricky. So 8 gram hemoglobin is not too low to initiate a transfusion. These are chronic renal failure patients and are accustomed to a lower hemoglobin over a period. So this patient was already on erythropoietin for maintaining the hemoglobin on acceptable levels. So in short, the answer is no to 8 gram hemoglobin. So if the hemoglobin is much lesser, say about 5, 6, and patient has some symptoms of frank anemia, then it will be better to build the hemoglobin over a period using erythropoietin and dietary modification before posting for the case. So it is not absolutely contraindicated, but one should be careful while initiating a blood transfusion in such a case. So suppose this patient was during surgery had a major catastrophic bleeding, and you have given all possible things. You have started good fluid resuscitation and given colloids if required, and started on vasopressor. Still the blood pressure is on the lower side, there is tachycardia. You may end up giving a blood and it is acceptable, but it should be sparingly used. It should not be a dictum that like in any other case you give the blood. Dr. Meena, you want to add something?
There is one more question just now we have received. Kindly comment about the dose of local anesthetic agents to be given in these patients.
So last Priyanka to answer this, then I'll add. Priyanka, what about local anesthetic dose?
So the books say that we should reduce the dose of local anesthetic by 25% because the metabolism and excretion is reduced. But in practice, we give the 1 milligram we give the normal dose only. We don't reduce it.
Okay. So yes, see, in any case, we are not using much of the blocks for these patients for a lot of reasons. We are very skeptical of using them. So it depends what block you are actually using. So for epidural, in any case, the dose requirement is not much and within the range. So we don't have that problem. The problem will occur if you give a field block. So whether you go for paravertebral or a restless spinal block or quadratus lumborum, where the volume of local anesthetic required is much, much more. So you end up giving 20, 30, 40 ml, depending on what block you are giving and what combination you are giving. So in those cases, it is not a bad idea to give the volume what is required, but reduce the dosage overall, say about 10 to 15%, to avoid problems because of because we don't know what is the metabolism going on in a CRF patient. The dosage is required is always, it is a good idea to give about 15-20% less, and we can still have a good analgesia with less volume of the drug, overall volume of the drug.
We don't have any more questions, sir. Very well discussed. I think students might have gained a lot from this case discussion.
Thank you, Namita. And I thank you to Dr. MD Kaur and the whole team for this opportunity. Though I'm not doing these cases quite often nowadays, but we did start renal transplant at RML about 10 years back. And it is an important
Yes, sir,
case nowadays.
I have done my first case along with you only.
That's true. So it is an important case nowadays because a lot of centers are doing it, and in addition to exam, it is important to know about this case because you end up giving a anesthesia to patient posted for transplant or a patient who is transplanted coming for a routine surgery. So it is an important case to know. Thank you.
Thank you, sir. Thank you, ma'am.
Now we'll move on to the next session. So now it is the quiz time. The first question here is a 26-year-old male who required dialysis every third day and presents for AV fistula creation under general anesthesia. His last dialysis was done yesterday. Which of the following drugs will have prolonged duration of action? A, fentanyl, B, neostigmine, C, atracurium, and D, methadone. The question 2. The factor associated with maximum increase in intracranial pressure is A, increased central venous pressure to 14 mm of mercury, B, hypercarbia with PaCO2 of 50 mm of mercury, C, ventilation with positive and expiratory pressure of 5 cm of water, D, bucking and cuffing on the endotracheal tube. Please reply in the chat box. Okay, now we'll have a short break, tea break, and then we'll proceed after 15 minutes. We'll resume at sharp 10:40 again after the tea break.
Welcome back after the tea break. So we'll continue with the next session. And it's my honor to invite the next chairperson, Dr. Pragati Ganju. Ma'am is Director Professor and is heading the Department of Neuroanesthesia at J.P. Pant Institute in New Delhi. And ma'am's area of clinical interest are neuroanesthesia and neurocritical care. We welcome you, ma'am.
Thank you so much. Yeah.
You're the right person to be chairing this session.
Thank you. Thank you so much.
Over to you, ma'am, for the proceedings.
Thanks. Can I have the CV of the speakers?
Yes, ma'am.
Yeah, sure. So we have two lectures in this session. The first one is by, just a minute, Dr. Prashant Kumar. He's a good friend. He's from Rohtak, Haryana. He's a professor in the Department of Anesthesiology and Critical Care at Pandit BDS BGIMS at University of Health Sciences, Rohtak. And he is a neuroanesthetist at core and is also practicing neurocritical care and also doing airway management, medical education, research. He's done a lot of research in COVID-19 and simulation skill training. And other academic milestones, I think you can see it on that screen of yours. He's been around